This program is brought to you by Emory University.
Good morning, everyone. Welcome to the first Heart and Vascular Grand Rounds of the year. We got a little late start this year, but we're really excited that Dr. Book has agreed to kick things off and get things rolling on a topic that all of us fear, and that is congenital heart disease. I said I thought a simplified approach to the Fontan Management was to refer to Wendy, but Wendy's probably going to give us a little more detail about that. And as all of you know, Dr. Book is the head of our Adult Congenital Heart Center here, has done absolutely a fabulous job building that center over the years, and is a true expert in this area. So we're looking forward to how to simplify managing Fontans. All right, Wendy.
All right, thank you. Make it a little darker so we can see. My main objective today is to provide a distraction from the chaos in Washington, D.C. this week. And if you learn just a little bit about single ventricle circulations, that's a bonus, but that is my main goal today. Anything I discuss is off-label therapy. There are no approved therapies for pretty much anything I do, which does make it more fun. We can think through what we want to do. So, a couple of diagrams of what a Fontan circulation looks like. And in order to understand how to manage a Fontan circulation, you have to understand the anatomy and how they're connected. In the adult world, you'll see these old atriopulmonary connections, the old style Fontan, where the atrial appendage or some version of this is connected directly to the pulmonary artery. And these right atria in these patients become massively enlarged. So, they might be 6, 7, 10 centimeters. The blood just swirls in there. They're a very inefficient type of Fontan. And the single ventricle, whether it's a right ventricle or left ventricle, is really irrelevant, is connected to the aorta. And more recently, and by recently, I mean the last 20 to 30 years, patients have had either a lateral tunnel or an extracardiac Fontan, and this is what's done today, the extracardiac Fontan, where you have a communication from the inferior vena cava that directs blood in the direction of the LPA, and the superior vena cava directs blood in the direction of the RPA. This communication here is called a Glen, and this is technically the Fontan, and the single ventricle part of it is the same. So this is important to know what type of connection your patient has, as we can treat some of the problems in the Fontan patient by converting an old style Fontan to a new style Fontan. Probably in the adult world, in an older population, about 2/3 are this old style Fontan and 1/3 the new style. And pretty soon 100% will be this old style as we're converting some of the older ones. It's important to understand how these patients do, and almost all of the data out there is from the pediatric world, and they talk about how great these patients do, how wonderful the long-term outcomes are. So for a single ventricle patient born who does not have any intervention, the median survival is roughly 2 years, many of them dying in infancy. So to have 74% alive out at 20 years is really good outcome from the standpoint of a pediatrician. And these are your competing outcomes of death, transplant, and takedown of the Fontan to pre-Fontan type circulation. So this looks really good to a pediatrician. To a 20-year-old who's sitting in your office, this is not good at all, because they're like, yeah, what? I'm done. Now the average survival is 22 years. So our goal, of course, is to get these people to be grandparents. And we're thinking through how do we turn this type of single ventricle circulation into one that can sustain life for a long time. This is why they die. And this is a meta-analysis of a number of different studies. But by far the most common cause of death is heart failure. And heart failure means a lot of different things, but when you actually look at failure of the single ventricle, where you have a low ejection fraction, this is the most common cause of death in the pediatric population, whereas many of the adults die with a normal ejection fraction. Sudden death is common. A lot of that is related to thromboembolic complications, so there's some overlap here. And then a smattering of other problems that we start to see more in the adult world, like liver disease, cancer, protein-losing enteropathy. The infections are typically related to immune deficiency from protein-losing enteropathy. And this is a different study that looks at the main risk factors for mortality, again, in a pediatric population. And you can see if you have tachyarrhythmia, thrombosis, PLE, it doesn't matter how many you have, it's not good. Your mortality is significantly worse than those that don't have any complications. And this is logical, right? If you have a Fontan circulation that works, you're going to do better than somebody who has a Fontan circulation that doesn't work. So I want you to keep this in mind when we move into the adult data. This is what the pediatricians see, and what we see on the adult side is a little bit different. This is my daughter, who's now 21 and going to school on the beach in St. Augustine, and she loves scuba diving with sharks, and she thinks this is a good idea. So this is kind of what happens in adulthood, and no different for our Fontan patients. She tells me that the sharks only eat people by accident, and I should not worry, that it's okay. That does not reassure me. These little crosses are deaths, and the majority of deaths occur between the ages of 20 and 40. Mostly in the 20s and 30s is when these patients start to die in the adult years. So what does a single ventricle circulation look like hemodynamically? And this is important to understanding these very late adult complications with the circulation. In a normal circulation, you have low right atrial and low left atrial pressures, and you have a pump in between. So you have a pump between your right atrium and your lungs, and that allows you to maintain a low right atrial pressure. In the Fontan circulation, you have no pump on the right side, and you have passive flow from the cava to the pulmonary arteries. So you have passive, non-pulsatile flow from the vena cava to the pulmonary arteries. And this has a profound impact on all of the organs long term that creates some of the complications we see. So by design, once you do the Fontan operation, which is typically done around age 3 or 4, your right atrial pressure now exceeds your left atrial pressure. You have to have a pressure gradient from RA to LA in order for you to get blood through the lungs, right? So what that means is when you're 5 and your LA pressure is 2, your RA pressure is 5. Life is good. When you're 25 and your single ventricle end diastolic pressure is now 15, your RA pressure may be 18 to 20, and that's not so good. So here's the simplified version of the Fontan management. Really only need to think about 3 things, although I'm cheating a little bit here. But always look for anatomic issues. This is the low-hanging fruit in Fontan management. If there is an obstruction in the circuit that's anatomic and you can fix it, you can improve the circulation, right? Arrhythmias are common, and I'll show you a little bit of data on that. All Fontan patients, I think, eventually develop arrhythmias, and they decompensate when they develop these arrhythmias, almost always atrial arrhythmias, although we do see some ventricular arrhythmia. And this is where I cheated a little bit. The associated diseases are many, but these associated diseases are related to this non-pulsatile pulmonary blood flow. In general, everything else that happens is related to dysfunction of that circulation. The circulation is no longer normal, and you have a number of different changes that occur as a result of that circulation. So this is an example of a Fontan anastomosis from the IVC to the pulmonary artery, and you can see there's stenosis here. You might see pressure gradients of 2-3 millimeters mercury here, which sounds like no big deal, but when you don't have a pump, it's a really big deal. And we can go and stent those and solve this problem. Arrhythmias are common over time, and this is still pediatric data. And you can see you've got significant increase in these intraatrial reentrant tachycardias, which are basically atrial flutter around suture lines. And that increases with time from Fontan. By the time they're adults, lots of arrhythmias. This is data out of the Mayo Clinic, and now we're getting into some more adult data, and this is looking at the proportion of hospitalizations that are due to each of these causes, and there's some others I didn't put up here. But in the black bars are your Fontan patients, and the gray bars are patients with congenital heart defects that have a 2-ventricle circulation. And you can see that arrhythmias drive hospitalizations in the Fontan population, and heart failure drives hospitalizations in the Fontan population. And arrhythmias being very, very common cause of admission to the hospital and decompensation. And these arrhythmias can be tricky to spot on the EKG. You have to be paying attention. A heart rate of 110 should make you think, is this really sinus rhythm, or is this a slow reentrant tachycardia? And if you see it, you call Dr. Lloyd, who fixes it, sort of. So once you've had an arrhythmia, you have more arrhythmias. So this is more data from the Mayo Clinic in adult Fontan patients. So once you've had an arrhythmia, you get to be at the top of this graph here, and your chances of being free of arrhythmias is pretty close to 0 as the years go on. So once you've had one arrhythmia, you're going to have another one, and they recur. And if you do catheter ablation, you can maybe slow that down a little bit. They still recur. And I tell the patients when we send them for an ablation, I don't know what Mike tells them, but I tell them it's going to come back eventually and we'll have to do this again. We don't tell them they're going to be cured of their arrhythmia when we do an ablation in a Fontan patient. The Fontan conversion patients, these are the old style Fontan patients that present with either atrial fibrillation or atrial flutter. And when we do this Fontan conversion, we convert them to that extracardiac Fontan, do a maze procedure, and it's very effective for managing their arrhythmias, and that is the main indication for doing a Fontan conversion. All right, so let's get into the cheating a bit here. So just a reminder again of a Fontan circulation. Pulmonary veins come to the left atrium, single ventricle to the aorta. You have to use your single ventricle to pump to the aorta. The vena cava end up in the pulmonary arteries either directly or indirectly depending on the type of Fontan they've had, and the ventricle is missing on the pulmonary side. So kind of two main things can happen here, and these two main things set the patient up for everything else that happens. The single ventricle can fail, and this is what happens in the pediatric world. We don't see as many of those patients in the adult world because they don't survive to adulthood without transplant. So they can develop ventricular failure just like you see in somebody with left heart failure. Except it's a little bit more of a problem when you have an EF of 20 and an EDP of 20. You've got a right atrial pressure of 22 or 23. The high right atrial pressures or the high IVC pressure affects the liver significantly. So you have very high pressures in the hepatic veins, and I'm going to go over the liver circulation in painful detail in a bit. But you have very high pressure in the hepatic veins, and this causes hepatic fibrosis, and it also causes portal hypertension, and you can have portal hypertension without having frank cirrhosis. And this is due to basically a functional outlet obstruction. The adult patients, like I've been saying, look different than the pediatric patients. They have worse functional class, they have higher central venous pressures, they have lower systemic vascular resistance, and their cardiac output is similar. And it's similar because the ability of a single ventricle patient to augment their cardiac output is very limited. If you can imagine no pump on the right side, it's very hard to augment cardiac output significantly. These people do much worse on the treadmill from day one than their counterparts with biventricular circulation. And in the adult world, almost everybody has hepatic fibrosis, almost everybody. And I think the one that doesn't probably is a misread. I think they all have hepatic fibrosis or they had their Fontan later in life. Defining Fontan failure is a great topic of debate in my field, and I'll just give you a couple of examples that are completely different. Fontan failure, to me, means failure of the circulation for many reasons, but in the literature it's been described from everything from with or without ventricular dysfunction, plastic bronchitis, and PLE, and blah, 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 blah. Lots of definitions. So I like to think of it this way. Fontan failure means you have circulatory dysfunction, and how can we simplify thinking about circulatory dysfunction? And I use this conceptual framework to think about it. So you can have cardiac failure. So either you have systolic dysfunction, diastolic dysfunction, or both. The heart doesn't work. The ventricular function is impaired. And these patients have a combination of pulmonary and hepatic congestion. Makes sense, right? And they look like a heart failure patient at cath. Their cardiac output is low, their SVR is elevated. More commonly in the adult world, we see this Fontan failure with a normal heart. And these patients are challenging, and they do poorly with or without transplant. So these patients have a normal ventricle. Their cardiac output is normal at cath. Their systemic vascular resistance is often normal or low. Their pulmonary vascular resistance, which is really impossible to calculate accurately in the cath lab because you have non-pulsatile flow and differential flow to the lungs, but we estimate it to be normal or elevated, and I'll show you some data on that. But most importantly, you have portal venous outflow obstruction that is often functional. And by functional, I mean your IVC pressure is high, and it's not a problem with the liver being cirrhotic necessarily. You can have this portal venous outflow obstruction causing features of portal hypertension in the absence of frank cirrhosis. And they have ascites, splenomegaly, varices. They can even bleed from those. And some do go on to develop frank cirrhosis. And then we have these patients that are kind of outliers. I won't spend a lot of time on them, but some of the patients have these lymphatic abnormalities where the lymphatics reroute and they start leaking lymph either into the bronchial tree or into the GI tract. So these patients have, again, a normal ventricle, and they typically have normal Fontan hemodynamics. They have an EDP of 4 and a Fontan pressure of 8, and you think, wow, you should be fine, but they have ascites, they have hypoalbuminemia, they have diarrhea, they're coughing up proteinaceous cast. It's a big problem. So these patients are a little different, and I won't get into that other than to say it exists. The ones that present with ventricular dysfunction, which is about a third of the adults that have Fontan failure, these are the easiest to treat, in my opinion, and respond the best to therapy. And they look, for all the world, like a heart failure patient. They behave like a heart failure patient. And the good news is they respond to heart failure medication. So we typically will treat these patients with beta blockers, ACE inhibitors, aldosterone antagonists, diuretics. We always do a heart cath first to confirm the hemodynamic phenotype before we start therapy because they can be mixed. And some of these medicines can be harmful if their SVR is low. But we basically treat them the same. Is there any data for this? Of course not. There's no data for anything we do. I've already told you that. But there is a little bit of data suggesting that there are abnormalities or upregulation of norepinephrine and sympathetic nervous system in single ventricle patients. There is a little bit of evidence in small studies suggesting that carvedilol will decrease heart size, improve ejection fraction, and clinical status in single ventricle patients. And then we have this problem where half of our patients have sinus node dysfunction by the time they get to adulthood, so the beta blockers can limit use if they don't have a pacemaker. So we have to be very cautious and careful and monitor these patients when we start beta blockers. So it's not for everyone, but it can help some. Diuretics are an important part of treating any kind of heart failure. They relieve congestion. And hepatic congestion is bad for the liver. The difference, I think, between the hepatic congestion we see in a Fontan patient and the hepatic congestion we see in a biventricular heart failure patient is the Fontan patient can live for 30, 40 years after the onset of hepatic congestion. And Andy, correct me if I'm wrong, but a congested liver in a heart failure patient is usually a sign of a poor prognosis in RV failure, and we typically don't see 30-year survivors. So I don't think we see the degree of liver impairment in biventricular heart failure that we do in these Fontan patients. There's, like I said, no data for anything. There is a dog study where they clamp the IVC to see what pressure causes ischemia in the liver, and 20 millimeters mercury is the pressure in a dog. In general, the patients do better with a lower CVP if it is possible in their circulation. All right, so I've told you already that many of the adult Fontan patients that have this failing phenotype have normal ventricular function and normal ventricular pressure. So why is that? This has been a big mystery. I've wondered about it for a couple of decades now. And this is why. You're looking at a patient who has ascites, who has edema, who has exercise intolerance. They feel terrible. They look terrible. And you take them to the cath lab, and their cardiac output is normal or high even, and their CVP is fine. We call them good Fontan pressures. What's wrong with you? You have good Fontan pressures. Why do you look so bad, right? So this is a big problem in the adult side. And this is what I think is going on with these patients. This is just a reminder of the circulation from the congenital heart doctor's point of view, which is the other side of the heart instead of the left side. And these are liver biopsies from Fontan patient here. And all of the Fontan patients have sinusoidal fibrosis. They have central vein fibrosis and portal fibrosis. This is common. And if you remember your hepatic perfusion or not, the portal veins are responsible for most of the perfusion of the liver. So the portal veins are perfusing the liver. The hepatic artery provides less of that hepatic perfusion. When you have obstruction to flow through the portal veins, and you can have obstruction to flow through the portal veins because you have cirrhosis and portal vein fibrosis, or you can have obstruction because you have basically functional outlet obstruction. So when your IVC pressure is high, your hepatic vein pressure is high, your central vein pressure is high, your portal vein pressures are high. So you have this splanchnic congestion that occurs, and you have these high pressures with no pressure gradient through the liver like you normally would to get blood through the liver. So what happens? Well, the hepatic artery has to increase flow to the liver to preserve perfusion to the liver. And you get this splanchnic vasodilatation that helps you perfuse the liver. And everything that goes on to cause that splanchnic vasodilatation creates a situation where you have increased circulating volume in order to perfuse the kidneys. And you have to increase your cardiac output to accommodate that increased circulating volume and the splanchnic arterial vasodilatation. So what happens in the Fontan patient? Well, I've told you they have a very limited ability to augment cardiac output. When I first started here, I was doing right heart casts for the pre-liver transplant team, and I couldn't believe people were walking around with a cardiac output of 13 or 15. It seemed just amazing to me. Fontan patient can't do that. So when they develop clinical portal hypertension, their cardiac output kind of caps out at a lower level. So what happens? They decompensate. You have redistribution of this volume with the clinical picture of ascites, edema, varices, splenomegaly, etc. So they look like a cirrhotic patient, whether or not they have frank cirrhosis. They do all have fibrosis. We've named this FALD, Fontan-associated liver disease, and it's characterized by preserved synthetic function. Typically, their LFTs, transaminases, are normal. You won't see those kind of laboratory abnormalities. They may have elevated bilirubin or alk phos from congestion. But what you really see are these hemodynamic changes in these patients. This is a multi-center study looking at the livers of Fontans at centers across the country, and basically this shows that you have problems all the way across the liver, and liver biopsies in this study were abnormal in every single adult Fontan patient. There wasn't one that had a normal liver biopsy, and they all showed fibrosis, and this is what we see clinically. And many of them had splenomegaly, ascites, and varices, and these are the things that show you that you've got clinical portal hypertension in that patient. Those are clinical features of portal hypertension. This is work Rob Elder did with us here, looking at the presence of varices, ascites, and splenomegaly. And those adult patients, and to get onto this graph, you had to survive to adulthood, so this is conditional survival to adulthood. Those patients who had 2 or more of varices, ascites, and splenomegaly did significantly worse than the patients who didn't have these features. This is about an 80-20 split. About 80% of the adults do well and don't have this clinical decompensation evident, at least not relatively early on in adulthood. So how do we treat these people? Hemodynamics, again, are important. We need to know what we're treating to treat it, and we tailor the therapy to those hemodynamics. In some of these patients who have this relatively high cardiac output at rest and a low SVR, they respond pretty well to midodrine clinically. It allows us to diurese them, perfuse the kidneys. Beta blockers have been shown in cirrhotics to lower portal pressures. Most of the data is in preventing recurrent GI bleeds, and this is pretty rare to have bleeding varices in these patients, but it does happen. And again, diuretics to relieve congestion. But if you don't reestablish renal perfusion, your diuretics do nothing, right? You have to perfuse the kidneys for your diuretics to work. Vasodilators can be very harmful, and the interesting thing is the clinical phenotype can change over time. So patients may come to us on an ACE inhibitor and they decompensate over time, and we take them off the ACE inhibitor and they're fine again for years, just by making that simple change in their medicines. The hepatic fibrosis, even in the absence of cirrhosis, increases the risk for hepatocellular carcinoma. We see roughly a risk of roughly 2 to 3% per year, which is very similar to cirrhosis for other reasons. And we see this in patients who have advanced hepatic fibrosis, whether or not they have cirrhosis. And we do routine screening in these patients for HCC every 6 to 12 months. This is one of the things that impacts long-term survival. And if we get to it early, we can do ablation down in IR and potentially push off the need for heart-liver transplant. Once they develop HCC and need transplant, now they're looking at a combined organ transplant. A multi-center study, I don't have the data up here, but a third of the patients with HCC present with metastatic disease. So that means we're not doing a great job of keeping these people in care and screening them to catch these before they're metastatic. And once they're metastatic, survival is very poor. And say a brief word about the pulmonary vasculature. It is not normal in these patients, and I don't know that we know yet what to make of that. Some of it is early, so you see pulmonary vascular changes before they ever have the Fontan. You see it in infants, and it may relate to the abnormal circulation, high flow through the lungs, not clear. We see changes late after the Fontan, so there's progression, particularly of that intimal thickening. And that is more typical of what you see in idiopathic pulmonary hypertension, pulmonary arterial hypertension. And that occurs late after the Fontan, and it's thought maybe to be due to this non-pulsatile flow, this abnormal flow pattern through the lungs. But we really don't know. I'm sure somebody knows, but I don't know. But this is kind of what it looks like. This is that late remodeling of the pulmonary arteries, and this is a normal. I don't know what the normals died of, but it wasn't pulmonary disease or Fontans. So there is some interest in looking at pulmonary arterial vasodilators in these patients. There are some single center studies. When we do, clinical trials in Fontan patients, we enroll like 9 patients or 12. So it's really hard to make anything of any of the data, but there's some very limited evidence that PDE5 inhibitors may improve exercise tolerance in these patients. There's also good evidence that exercise improves exercise tolerance in these patients as well, which is cheaper. The abnormal lymphatic patients are typically pretty dramatic in their presentation. They're rare. You don't see them too often, but the ones that have this you see all the time in the hospital. Mostly on the adult side, we see protein-losing enteropathy, which looks like profound hypoalbuminemia. They have albumins in the 1s, and they have ascites and edema and hypotension, and they really don't do well. They don't feel well. They can develop hypogammaglobulinemia with IgG levels in the 100 range. They come in with bacterial infections and septic shock. So these patients, there is a 30-year literature history of pixie dust, as I like to call it, that has been said to cure the PLE, right? But it's a waxing and waning disease, so you can really pretty much publish any case report on any patient that you've cured it with whatever. So our pixie dust here is midodrine, and we have 3 patients at our center where we have completely reversed the PLE and had years of remission on midodrine, and now there's 2 at Vanderbilt with the same good success rate with this, and this is better than anything else out there so far. There is Yoav Dori up at CHOP, who is an interventionalist in the pediatric world who has gotten into the lymphatic business. So I don't know how he does this, but Doug, you probably could figure this out. But they get into the lymphatic system with their little catheters. They find this little communication, and they're occluding these communications, and they're having good success with that as well. They open up new communications down the road, but they're the only center in the country that I know of that's doing this for PLE. The other one is plastic bronchitis, and if you ever see somebody with this, you'll never forget it. Most of them die in childhood. They cough up these large proteinaceous bronchial casts. They might be 5-6 inches long. It's a horrible problem. And it's the same thing. The lymph is just pooling in the bronchioles because of these communications where lymphatics are looking for an outlet. And Yoav Dori up at CHOP has had very good success treating plastic bronchitis with interventions. So that's enough of that. If you ever see that, send it on. In regards to Fontan failure, hopefully you understand it's not just about the heart. We have to base our treatment on the physiology and the hemodynamics, and that physiology changes over time from pediatric to adult life. There are changes across the lifespan in how that single ventricle is interacting with the other organs and how that affects the hemodynamics. So this is my daughter again with her shark friend. Sharks are our friend. She tells me she's studying teaching down there on the beach, but I'm not sure exactly what she's doing. But she's having a good time. So when all else fails and our medical therapies have failed and our interventions have failed, transplant is really the only treatment that gives these Fontan patients a good long-term outcome. So everything else is a Band-Aid, And those Band-Aids can get these people along for 10 years, 12 years. But if we really want to impact outcomes, transplant is the way to do it. And congenital heart disease is a small fraction of all adult transplants. It's much more common indication in the younger ages, about 10% of the younger age group. And this is increasing over time, Andy. More and more congenital patients coming for transplant. In general, we want to list people for transplant when we think they're going to die in the next year or so, when we think they're going to do better with a transplant than without a transplant. And that's really simple to say, but really difficult to figure out in a Fontan patient. Prognosis for the Fontan patients, there's a number of things that we've looked at. Cardiopulmonary exercise testing is the standard for biventricular heart failure, acquired heart failure patients. We lack a clinical score, although we'd like to develop one. MELD-XI is basically the MELD score without the INR. All the Fontans are on Coumadin for one reason or another. And that really just looks at creatinine and bilirubin. And then there's the features of portal hypertension. So the MELD score looks at synthetic issues in combination with physiology. VAS score looks at portal hypertension and physiology. So cardiopulmonary exercise testing, we know that the patients that do worse on the treadmill in regards to peak VO2, peak heart rate, do worse than their counterparts that have a higher VO2, better exercise tolerance, and better heart rate response. But what really predicted outcomes here in this study was change over time. So if you looked at them a year apart, if you had a drop in your VO2 and a drop in your heart rate response worsening as opposed to stable exercise parameters, those were really the patients that had a worse prognosis. So if you didn't do well at baseline, but you did the same at follow-up, you're probably going to be okay. It's the ones that have a change over time that seem to do worse. This is out of Boston. This is the MELD-XI data. The problem with MELD-XI is the poor prognosis in this study, and these are the highest MELD scores greater than 18 compared to a low MELD score of less than 11. The problem with the MELD score in this study is that the poor prognosis was driven almost entirely by the creatinine levels, although there was a little bit of added predictability by including that bilirubin in the MELD-XI score. But the big problem is these patients, once they hit 18, it was just, they just fell off the cliff. So it was kind of too late to get them to transplant. But if you look at the next group over, it's too early. So this, so far, is kind of a work in progress. This is one of the things we track in our patients, but we're not sure what to do with it yet. And I showed you earlier the VAS score, which separates them out pretty nicely. When we transplant people for Fontan failure, basically this is high risk, high reward. So they have a very high surgical mortality. It's a complicated operation, but their conditional survival is equivalent to other indications, probably better than other indications. And those with preserved ejection fraction have the highest mortality. And that's probably because the reason they're failing isn't because of the heart alone, it's because of the heart and what the heart has done to the other organs, and we're not transplanting the other organs. Waitlist mortality is very high, and this is an old pediatric paper, but basically those on inotropes or on a ventilator had a very high waitlist mortality. So it's hard to get these people to transplant. It's hard to get them to survive transplant, but if you do, they have really good long-term outcomes. This paper looked at mortality across the country specifically for failing Fontan patients who had a heart transplant. And you can see the results are all over the place, but in general, you're looking at a 20% operative mortality for the Fontan patients. We did a little better in Atlanta, of course, than the other places. And this is why. It is not unusual for these congenital heart transplants to take 12 hours. It's a long operation. It takes a long time just to get to the heart. There's reconstructions that have to be done when they do the transplant. They've got to reconstruct the cava, the pulmonary arteries. They may have to create new pulmonary artery. A lot of surgical issues that are common in these patients. And most of them, the Fontan operation is done in 3 stages. So the transplant is best case scenario, sternotomy number 4 for these patients. Because of all this, they bleed and they have early hemodynamic instability. That's very, very common. They have a long vent run, long ICU stay, long length of stay, and et cetera, et cetera. So renal failure, all these complications are common. And then we throw in the reality that we have a very difficult time measuring pulmonary vascular resistance in these patients, and that just further increases their poor outcomes. And then on the donor side, I hear a lot from pediatric cardiologists when I talk. They say, why don't we just transplant these people earlier? Why do you adult people wait so long? Why do you wait till they're so sick? Why don't you just transplant them earlier? As if it's that simple, right? And the reason we don't is we have limited number of donors, limited resources, and the allocation system prioritizes the sickest patients. So if they are not sick enough to print up for transplant, they're not going to get transplanted. And when they get sick enough to print up for transplant, it is really hard to keep these people alive. They just get to the edge of the cliff and off they go, and it's very difficult to keep these people going to transplant once they meet those adult therapy-driven criteria. Many of them are highly sensitized. They have antibodies related to multiple blood transfusions, and this makes it harder to find a donor and increases the risk of complications after transplant. So that's why we don't just transplant them all earlier. And they can do really well. As I showed you, 80% of them are doing fine. It's 20% that are not. And we wouldn't want to transplant somebody who's going to do well for the next 20 years when they don't need it. So just to summarize, high risk, high reward. And it is the most effective circulatory support with the best long-term outcomes for these patients. But it's for the minority. And then we have the added question of, do we put in a heart or a heart liver? I've told you many of them have advanced liver fibrosis. And this is a question we'll be asking ourselves forever, but once they develop hepatocellular carcinoma, it's now a heart liver. And if we transplant them, we still screen them lifelong for hepatocellular carcinoma because they can develop it after transplant. We have to keep an eye on that. This is a more peaceful fish, different fish. Mechanical circulatory support, I'll just say a few little things about what's out there. If we put the device between the single ventricle and the body, that's like same as when we do it in biventricular heart failure. So I'm not going to talk about that at all. What if we put the device between the Fontan and the lungs? And this would help all of those failing Fontans who have normal ventricular function, in theory. But how do we do that? It is really not as simple as just sticking a device that's meant for the systemic ventricle into the Fontan circulation. So if you put an IVC to PA device, you're going to have retrograde flow up the SVC, right? Or competitive flow with flow coming down from the SVC. So you have to work through this cavopulmonary connection and figure out how to get the blood to come down from the SVC, up from the IVC, and out to the PAs without competing in the middle. And Mark Rodefeld in Indianapolis has been working on a cavopulmonary assist device for a long, long time. And I'm going to show you just a little for fun stuff here. This is his device. And you can see the blood coming down from SVC, up from IVC, mixing in the middle and shooting out to the lungs. So it's a very clever little thing. And basically just this little rotor in the middle that does that. That's my engineering thing, Bob. So I'm going to end here. In 2018, the congenital world got guidelines. Woo, very exciting. We have guidelines. And basically for the Fontan, these guidelines say do surveillance for anatomic issues and correct them if you find them. Treat arrhythmias aggressively. Don't let them sit in atrial tach. They don't like it. Do a cardiac catheterization if you're not sure what's going on, and figure out the hemodynamics and tailor your therapy to those hemodynamics. Look at the liver. It gets sick in all the adults, and you don't want to miss hepatocellular carcinoma. It's very treatable early on. It is very untreatable if you miss it. And it can go from early to metastatic in a year. So it's one of those things where screening has high yield in these patients as far as impacting long-term outcomes. Transplant is the best long-term outcome, and blah, blah, blah. So those are the guidelines, and you can look them up. They're on the ACC website. And I'll leave you with these 3 ideas. These patients are at risk for multiple problems in multiple organ systems that present in similar ways, and you need to think through what is causing the presentation. Treatment needs to be tailored to that clinical situation, and it will differ between patients. They're not all the same. And heart transplant is really the best long-term mechanism of giving these patients a good outcome, but it's high risk, high reward. So I will leave you with that peaceful picture, and happy to take any questions.
So that was great, as expected, and we're really lucky to have you in the adult congenital heart team here. I'll start out with just one question about the pulmonary changes. You showed sort of arterial remodeling. So in the cirrhotics, do they develop AVMs like other cirrhotics do? And that must, if so, that must make the pulmonary vasculature even more complicated, I guess. Right?
Yes, is the short answer. They develop, in pediatric cardiology, we call them AVMs. Technically, they're occurring at the capillary level as they do in cirrhotics, and they look identical to what you see in a cirrhotic patient. They're capillary level blush. These patients get blue and bluer over time, and if you put them on a pulmonary vasodilator, they get worse. Yeah.
Okay, other questions from the group? I'll ask one more while Andy's getting ready. So do we need different transplant guidelines for these patients?
Now, you know I'm going to say yes. We need different transplant guidelines in general. We need a risk score, a heart allocation score like they have for other solid organs. And the changes that are going into place in October for the heart allocation system, it's still therapy driven, but they're actually collecting data, and I think that is going to lead to allocation risk score.
When just a question related to when you were talking about renal insufficiency, use of diuretics and that type of thing, and talking about perfusion, sometimes the renal perfusion is related to such a high venous pressure. But could you give us, some sense as to these patients who come in, frankly, volume overloaded with some degree of cardiorenal syndrome? What do we use as parameters on when we're over-diuresing, how much diuretics to give, when to give, possibly inotropic support, that type of thing?
Yeah, so the short answer is if there's any question, cath is useful. But in general, I mean, there's a number of things that can give you a clue. If your pulse pressure is narrow, it's probably a low output situation, and they may benefit from inotropes. If their pulse pressure is wide, it's probably a vasodilated situation. They might benefit from vasoconstrictors. The patients that have this vasodilated phenotype are hypotensive. They're not normotensive. They've got blood pressures of 90/50 or 90/45. They look vasodilated. The congestion issue with the kidneys should respond to diuretics and get better. Some of these patients need very high doses of diuretics, just like the heart failure patients, to achieve that diuresis.
Okay, I figured out the microphone. The lymphatic changes that you see in these patients, do they resolve if they're transplanted, or are those patients just too sick and they never get to transplant?
The transplant is curative for the PLE and the plastic bronchitis. It goes away, never comes back.
How long does that take?
It can take a few months. And same with the physiology that you see with the portal hypertension, that vasodilated state, that can take a few months to go away after transplant as well.
Well, if there are no more, just thanks so much for a fantastic talk. That was really, really great.
I'm glad you enjoyed it, Bob.
The preceding program is copyrighted by Emory University.